I'd like now to introduce Simon Craig. Simon's from Better Care Victoria, and he's a systems improvement and specialist and industry coach. And in fact, we've just heard some very good things that you can pick up on, haven't we?
Yeah.
Great.
Thanks very much for having me. Can you guys all hear me? Yeah? I've got a loud voice anyway, I'm told, so microphones just add to that. So I've got my pointer. Have you taken that pointer, Christine? Here we are. Just a little bit about Better Care Victoria. I'm from Better Care Victoria. Some of you might know Better Care Victoria was formed in 2015, the end of 2015, primarily out of the Duckett Review. The idea is that we can build capacity in our health services through scale and spread of innovation and improvement. That we do good, but we don't do good consistently, and when we do good, we don't scale and spread that across to even within our health services, but also across health services. What we've done over the last couple of years is we fund innovation projects, and some of you might be involved in some of those innovation projects that we funded. We have leadership programs that we fund, and we have a couple of collaboratives. One's called a partnership, one's called a collaborative. The Improving Emergency Access Collaborative, which some of your health services are involved in. And more recently, we've just started the Specialist Clinics Access Improvement Partnership. The idea is to get the health services talking. What does work? Let's scale and spread that and accelerate some of those learnings. I've been asked today to just give you a bit of an overview about change. Now, a lot of the big words you guys were using before, I'm straight over my head, but I can understand what you're trying to do. I don't understand the detail. My background is not clinical, and so I'm not going to stand here and try and tell you how to suck eggs clinically. But what I do know is change management, and I've done that through many different industries. And in health, what is a complex environment, complex being we can't sit in a room and join the dots. We can't predict always what the outcomes of something over here might do over here, means that change management is really, really important. So I've only got 20 minutes, so I don't have too much time to give you a blow-by-blow explanation of how you might do this, but maybe just some food for thought. So when you go back to your health services and you start looking at what can we do, how can we use these guidelines, or what are we calling them? Guidance. How can we use this guidance in our health services? That maybe we've got some things that we can think about. If I'm talking to the converted, you can sing along with me. First thing I want to do, and I want this to underpin what I talk about for the rest of the day, is I want to talk about what change is and what it means to us as people who work in health services. At the end of the day, all these things are implemented, maintained by people, and that's a really important point. First thing is, change is hard. Not the change, not the discrete change, not the act of doing something. The change is hard. So the move from we are doing this now to we are doing this now, that's the hard part. So even though these guidances might be quite simple individually, when we ask people to change the way that they work, that is a hard thing. And what I'll do is I'll help demonstrate that. Here's Johnny Bravo. I like doing presentations with Johnny Bravo on the screen because it makes me just seem a little bit cooler. Now, Johnny Bravo crossed his arms this way. And the reason he crossed his arms this way is because we found that it's best for patient care and it's best for patient experience. Our access into our health services is improved when we do this. And we found this out 10 years ago based on the evidence and the science at that point in time. So what I'll do is I'll get everyone in the room, just cross your arms. However you cross your arms. Feels comfortable, doesn't it? It's easy. You all look closed and like you're not listening to me, but I know that I've told you to cross your arms, so I won't take offence. Now, we've done some studies, and studies have come out, and we've done a lot of background investigation, and there's a lot of evidence to suggest that actually the way that Johnny's crossing his arms no longer makes sense. Technology's moved on, we've had medical advances, and the environment that we are now working in, the patients we're now treating, the clinicians we have, actually this doesn't make sense anymore, so we need to change that. And for the sake of patient care, patient outcomes, access into our health services, we need to change to this. So what I'll do is I'll get you all to just cross your arms the other way. Right, who couldn't do it? There's always one or two, right? All right, we can laugh at those people. Right. So remember who those were, and when you're having a coffee later, get into them. For the most part, we could do it though, couldn't we? For the most part, we could do it. And that change is not a hard thing. Now, all the things you're talking about are significantly more difficult than that change. But with your arms crossed, I've got to actively think about it. With your arms crossed the other way, how does it feel? Uncomfortable, bit foreign, bit unusual. It's not the change that's hard, it's the act of change, because we're used to doing something else. When we change, it's a little bit more difficult. Something's not right, it feels not comfortable. What if we made a social contract and we came to an agreement that from now on, for the rest of the week, we're going to cross our arms the other way? While you're thinking about it, it won't be an issue. So we went to that launch and we all agreed that we're going to cross our arms the other way, and so we'll cross our arms the other way. What happens when you're back in your health services, providing care for patients, saving lives, delivering babies? What about when we're under those pressure, we've got too many women rocking up to give birth and not enough birthing suites, and we've run out of whatever you guys run out of? Yeah, staff, right? You've run out of staff. Let me guess, we've just come through winter. And you cross your arms then, when you're not thinking about this, how do you think you're going to cross your arms? You go backwards, won't you? Now, is that because you're not a team player? Is that because you don't care about what the evidence says? Is it because you're not engaged and you don't want to support your colleagues? Is it because of anything like that? It's not. It's got nothing to do with that. What it's got to do with is change is hard. The act of change is hard. We're asking to go from here. We've done it for this way for a long time, and we want to change it to a different way. Now, the reason I say that is because the rest of what I'm going to talk about is just some thoughts and maybe strategies and things you can think about when you're taking these back to your health services. But if it underpinned by this fundamental respect that the people who are providing care, the people who are following these guidances, the people who need to implement this and take care of our patients, if we recognise that the act of change is hard, it will mean that we're going to approach it in a slightly different way and maybe a little bit more successful way. I'm going to use the PDSA cycle, and please don't roll your eyes if anyone is. I'm using PDSA just because I think it's something of a common language. Now, we don't need to use PDSA, but I'll use PDSA just to hang this discussion on and just to frame what we're going to talk about. It's a very old concept, and really what it was an attempt to bring science or scientific thinking into the management world. The idea that we have a hypothesis, we have a plan that if we do this, this will occur. We do, if you like, an experiment, or we implement. We study what the results are back against our hypothesis. Did what we predict was going to happen, and then we act. Based on what this was, based on what our outcome of our experiment was, we take some action. We decide what the next step is. Done properly, this can be calm, it can be methodical, it can be engaging, people can get involved. Done poorly, it can actually be worse than nothing. Actually, you can go backwards. And people don't like to talk about this, but change can actually end up as a negative if it's not done right. And we'll talk about how that can come undone. And already I'm starting to hear some of these things, and they're going off like light bulbs in my mind, saying they're the kind of things that if we don't address, we'll end up going backwards, and this will be a burden rather than something that should be positive and fundamentally good. The best part about PDSA, and the reason this is so important to talk about, the best part of PDSA is the plan doesn't have to be right. And if I'm making a Lego block house with my daughters, well, I can get the plan right. The plan's easy. I count how many bricks I need. I can follow the instructions that Lego give me. It's easy. But we're talking about health. We're talking about a complicated, but worse than that, or more difficult than that, complex, which is this butterfly effect, that something happens over here and has an impact over here. And we could never have drawn those dots sitting in a room thinking about how things might work. Now, the reason that's so important is because we don't have to get the plan right, because we have this study to check, did it work? And it sends us on a loop again. So it's okay to make errors as long as they're safe and we're not hurting anyone. And as long as this cycle's small enough that we pick up the problems early enough before certainly anyone gets hurt, but also before we start to frustrate our staff or those who are using the systems too much. Lisa made a really good point early about the fact that our health services are all different. We've got different patient cohorts, we've got different experience, we've got different equipment. We heard that some health services don't have birthing suites, some do have birthing suites. So we're all very different. What that means is this becomes even more important because we're going to need to adapt these guidances to our own health services. We can't just implement them blindly. We can't assume that it's a one-size-fits-all. We're going to need to tailor them to what we do. This is PDSA taken more generally through the life cycle, if you like, of the way we work. I'm going to talk about this stage here, which is this step change, this phase of we're currently doing this, we now want to do this. Now, of course, that should be because we want to improve safety, quality, access, whatever it is, and we'll talk about that. That's a really important starting point, that we want to take a step change to improve, and we'll unpack that. But the only thing I want to talk about here is it doesn't stop here. And the reason it doesn't stop here is because things change. Things continually change. We have seasonality. We've just come through winter. We have technology that's constantly changing. We have medical advances that can continually changing. We have staff that are rotating. We have medical staff that are rotating. We have new staff that come on board. So everything is continually changing. What that means is what works today may not work in a month's time, 6 months' time, a year's time, 3 years' time. And so if we're not constantly looking, we're not constantly talking to the guys who are providing the care to our patients, we actually may go backwards. We could actually lose those gains because we come up against problems that we hadn't seen. We come up against capacity constraints or whatever it is. So let's go through them. Plan. Now, I said before that you get a second chance with the PDSA cycle, but there are some things you don't get a second chance with. And I want to talk about the key things. I don't want to go through this in detail. What I do want to go through is the key steps, if you like. And if you understand these key steps, and we take these key steps back to our health services, you're not going to go too wrong. So the plan is all about what do we want to do, and importantly, what are we trying to achieve? And that's really important because PDSA doesn't work unless you make a prediction of what you're trying to achieve. If you can't say what you're going to try and achieve, you can't then work out, has it worked? Have I been successful? First one, and this is really important, is who are your change champions? Now, my experience, we do this, and this is not we as in health, a lot of people do this, we don't do this very well at all. The easiest way for us to do this is think about who is impacted by the change that we're making. Now, our first group of people that we need to be thinking of are those who will directly have to change their behaviour. Think about that Johnny Bravo situation. Who are those guys? Who are the Johnny Bravos in our health services who are going to be changing the way that they work because of what we're going to be implementing? Now, if you know who they are, that will then tell you who your change champions are. So if we're asking our obstetricians to change, there's something they've got to do different, perhaps you should have an obstetrician leading a change. If we're asking midwives to change, maybe we need a midwife. We're asking our administrative staff, maybe we need administrative staff. Now, if I said to you, if I came to an obstetrician or a midwife or any of you guys and said that you should be changing the way you work, and this way you work doesn't work anymore and we need to do it a different way, I'd quite rightly expect that you'd say, well, who are you? What do you know about this? And that's an extreme. Of course, I'm not from a medical background or from a healthcare background. But even within the healthcare background, you can still have those dynamics. So think about who we're asking to change and think about who's best to lead that discussion and lead those changes. We tend to listen more, we tend to engage more with our peers. And so a peer-led improvement or a peer-led change will often be much more successful. Second one is establish the objectives of the change. What are we actually trying to achieve here? And often this will mean that we need to actually sit down and think about it as well. So we come here and we're launching these new guidances, which is great. But actually within your health services, what are you actually trying to achieve by doing this? And I'm sure there's some really great things there, but unless you can articulate them, it's going to be very hard to, one, check whether you've been successful when you've implemented, but two, it's next to impossible to get people on board. If you can't explain why you're doing something, and we'll talk about that here, if you can't explain why we're doing things, people will quite rightly be very difficult or very slow to get on board. So what are we after? Are we after adherence? Are we after an improvement in safety? If so, what is that? What is safety? How do we measure it? How is that quantifiable? Is it quality? Is it access? What is it? Let's be clear about what we're trying to achieve. Third, establish a rollout strategy. Now, I'm using PDSA as a concept or a framework to talk through here, but within your own health services, you're going to have your own frameworks and you've got your own project management groups. You might have redesigning guys or whoever it is. You'll have your own frameworks to work through, but develop a strategy. What is the plan? And I'm a simple man. I like to think in simple terms. The 4 W's. Who is changing? When, where, and what. So if we start firstly, what particular bits are we going to take at this point? Are we going to implement them all at once? Or are they going to be over time? When are we going to do it? Is it going to be staged? Are we going to do it immediately? We're going to go back now and put these on the internet and say it starts as of tomorrow? Or there's going to be some communication period and then implementation? Is it going to go campus by campus? Or the where? So which units first perhaps? We're going to focus in the birthing suite or in the wards or on this campus or all the campuses? How are we going to think through that? And the who. Again, we need to think about who our stakeholders are, who's engaged, and who's been asked to change the way that they work. Remember, I continually go back to that Johnny Bravo, and I've actively got to think about it here. Whoever we're asking to change, they're the ones that we need to know first and foremost, because they're the ones who are going to be impacted the most. And the last one, and this is very important, and actually communicate encompasses all manner of sins. Communicate the change. Communicate, communicate, communicate. I've seen some health services, and I won't name names, where we've rolled out pathways, but then when we say, have we actually explained these to anyone, that no one in the room can put hands up. We've emailed them out, or we've put them on the internet and we send a link. We've actually not explained what we're trying to do. So again, we think about who the stakeholders are and we make sure we communicate to those guys. Start with the why. Some of you might have heard of Simon Sinek's golden circles. You start with the why, then the how, then the what. This is the what. These are the what. These are the things that we need to do to achieve the why. If I was to say to you, in all seriousness, we need to cross our arms differently from now on, what would your question be? What would your first question to me be, do you think? Why? So whenever we're doing any change, shouldn't we open with why, predicting, knowing that actually the people we're asking to change, their first question, whether they ask it or not, and sometimes they won't ask it, and that's a huge problem, but the first question should always be why. We're not talking to robots, we're talking to very intelligent people here. Of course, they should be asking why, and we should be ready to answer that. So the easiest thing to do is start with why. This is where we are, this is the gap, we need to improve because of these reasons. This is how we're going to do it. Think about how we're going to communicate. So what's the media for communication? And again, it's going to depend on who your stakeholders are. Those who just need to be informed, well, we can just perhaps inform them. Maybe email's okay for them. Maybe posters or campaigns, whatever you need to do, maybe that's okay. What about the guys who we're asking to change? What about those who provide the care, who we're going to say, right, we're currently doing this, we need to do it in a different way? Perhaps an email, perhaps a 10-minute slot in a multidisciplinary session, or whatever it is, isn't enough. Maybe think about education. How do we educate? How do we make sure that people really understand what we're talking about here? And it's not just a cursory, by the way, these new things came out from the department and we need to use them now. Then we get into the do. So that we've done our plan, we know what we're trying to do, we know who our stakeholders are, and we've got some people who are leading it, people who are peers and can talk the same language as those who are going to be asked to change. We implement the plan. That's not so hard. Just implement the plan, follow what we're going to do, refer back to it often, make sure that we're clear. This is the issue. I've deliberately made that bold. Maybe I should have made it red. Expect problems. Now, the reason that's so important is if we don't expect problems, we kind of don't want problems, and if you don't want problems, well, you'll find a way not to find them. If we expect problems, we'll look for them. We'll actively look for them. We'll measure. We'll be asking for where the problems are rather than trying to convince ourselves that things are working. The problems are the bits that are going to undo this. They're the things that are going to get in the way. Think of them as the barriers. As we go through the doing, what we'll do is that we'll have tiny little cycles where we'll get halfway through and we'll realise, oh, wait a second, this isn't working. And some of you guys came up with some things like the balloon catheter. Do we do that in the water in the birthing suite? Wait a second, we hadn't considered that. That wasn't part of our plan. Wait a second, we're going to have to sit down as a group and work that out. We can't look at the guideline for that. We can't look at the guidance for that. We need to look at, in our own health service, what works. So we need to get people together and say, right, we plan to do this. It's not working because of these reasons. We've come up against a barrier. What are we going to do about it? You've got all the intelligent people who know what they're doing. Decide what you're going to do. Other examples of barriers that we might come up against are things like basic things like IT systems or forms or equipment or staffing patterns, whatever it is. These are the things that will get in the way of these things being implemented. And if we push forward, we ignore those problems. Oh, okay, the IT system's hard. I know you need to go back to the computer 10 times more now because of the change we've made. And I know it's difficult, but just do it anyway. We've got to think about what that does to the people we're asking to change. We've now added to workload. We've now added to frustration. And that frustration will spill over and actually start to taint what is fundamentally a good thing, what should be a positive thing. Then we get into the study. I'm zooming through it here, but now we're into the study. We want to see now, has it been effective? Is it working? Has our plan worked? For an effective change, there's really simply two ingredients. One, we implemented our plan, and two, our plan worked. So if we implemented our plan and the plan worked, we'll have an effective change. Often what we do though is we measure the outcome, but we don't measure whether we implement it. And you see this time and time again, where we didn't implement the plan, we didn't do this, but we don't know it because we didn't check it. We didn't check that everyone was educated. We didn't check that everyone rocked up to training. We didn't check that the new staff who've just arrived have also been trained. We didn't check that we had the right equipment. We just assumed that we did that. And the change didn't work. And so then we go, well, that must have been a rubbish plan. These guidelines don't work. This is all broken. So when we're checking, is it working? Remember, we're looking back against our initial predictions. Is safety improving? Are we using the guidances, our internal guidelines? Are we using those? Whatever it is, whatever we predicted, whatever we were aiming for, is our outcome, and so we can measure that and we can see how we're going, and we can talk to people. Is it working? We also need to be mindful of, actually, did we even do what we said we were going to do? Because if we didn't, it's probably no surprise that we're not getting the outcome we wanted. So just to be mindful there that when we do implement, we need to be mindful that if we haven't implemented, we probably shouldn't be expecting those results. In the study period, now I'm a visual learner for those of you who probably haven't worked out already. I like to think of it like this. When we start something new, we need to believe that things are going to go wrong. That's the easiest baseline assumption, is that things are going to go wrong. Now, let's say I want to stop speeding. I need to change the way I behave. I need to change the way I drive so that I no longer speed. Now, I've got two options. I can wait for reporting to come through, and me and my wife can stand next to my letterbox. And when we get a speeding fine, we can sit down, we can work out strategies as to what might have happened and how I might improve it in the future. Or I can just manage my speed and look at my speedo. So what's your speedo when you're implementing these changes? What's going to tell you that something's gone wrong before we have a clinical incident, before we end up realising 3 months down the track that no one's used these changes? Big problems start small. And following on from that last slide, if we see the problems when they're small, before they've had a chance to frustrate people, before they've had a chance to taint the whole change as something big and burdensome and something that was ill thought out from the start, before it gets to that toxic stage, if we can see the problems when they're small, we can nip them in the bud. Oh, you don't have the right equipment. Well, let's provide the right equipment. We were a bit unclear here. Well, let's clear up how that should work. And lastly, act. Celebrate the success. Not only locally, but also within your health service. Make it known that we've done something and it worked, and there was success, and people were happy with it. Success breeds success. It's contagious, and what it means is that you'll be better set up for future. And standardise the practice. So I know fundamentally we're talking about variation reduction and standardisation, but make sure that it's part of our onboarding process. Make sure that orientation and training is built into our existing guidelines and those kind of things. So I got my 5-minute warning about 5.5 minutes ago. So I'll leave you with 3 points. 3 points from what I've just said. Firstly, think about Johnny Bravo. It's not, even though the change might be easy, the active change, we're moving from here to here, is not easy, and we need to be mindful of that and respect those who are providing care to our patients, that if we're asking you to change, that's not an easy thing for you to do. Secondly, approach it in some sort of structured way. Any structured way is fine, as long as it's a structured way that'll allow you to explain to people what we're doing and why we're doing it. And last one, see the barriers. Have a genuine appetite for the problems that come up, and make sure that you address them. Don't sweep them under the rug, because they'll come back to bite you. Thank you very much.